Welcome everyone to another episode here, Doctors of Podiatry. This is a continuation of an original video that we posted on YouTube as well as Facebook. The one that says along the lines of high grade, sprain, regenerative medicine baby or something like that. But anyways, the patient is back. We're gonna go ahead and in this particular video, we're gonna tell a story. I'm gonna take you guys from start to finish. From the numbing of the area all the way to the end of the procedure. So I'll go ahead and we'll do little clips. I'll edit it, just kind of plug it all in together, and then we'll definitely post it today. Just to refresh everyone's memory, this patient has been battling a chronic pain to the lateral aspect of the ankle. The MRI basically showed a high-grade chronic sprain of the anterior talofibular ligament in conjunction with an inflammation of one of the joints called the subtalar joint in the ankle, which is right in there, right? There's a joint in between the heel bone and the talus, which is here. In there, there's an abyss, so to speak. And inside that abyss, there's a lot of inflammation. It's what we call the sinus tarsi, the abyss. So if there's inflammation in the sinus tarsi, we call it sinus tarsi syndrome. So we're gonna go ahead and perform today, number one, a percutaneous microtenotomy, also known as the dry needling. Number two, we're gonna go ahead and infiltrate PRP into not only the affected ligament, one of the three, and then we're gonna go ahead and inject a little bit of PRP also into the sinus tarsi. So without further ado, the first thing that we're gonna go ahead and do is numb the area, okay? So let's come around here. Let's make sure okay. There's a couple of different nerves around here, right? This is the area that we're gonna treat, also here. So we're gonna go ahead and right here, there's a couple of really important nerves. And I always apologize in advance to the patients. Again, you guys all know me very well. You know, what you see is what you get. I like people to see what we're doing, and we get a little stick here. And I tell the patient they're gonna feel a lot of burning, kind of like that, a lot of burning. You can see how kind of go like that. Okay. And then we're gonna go a little bit more here, just to make sure that she doesn't have any discomfort. A lot of burning on the back, a lot of burning, a lot of burning, a lot of burning. And we come back like that. Okay, you're doing great. Okay, so now what we're gonna go ahead and do, okay, just come around here and inject a little bit. This will definitely this is like the barrier, the first one. Now we're gonna go for a second little barrier here. I don't like to inject the anesthesia close to the area where we're treating, obviously, right? And these are a very, very little pinch. These are very sensitive areas. A lot of burning, a lot of burning, a lot of burning. Excellent. Right? And that's it. Okay. So, first part of the procedure. Now we're going to put a stop to it, and then we'll show the next part of the procedure. Okay, so now we're going to go ahead and move forward with part two of the procedure. We've waited a couple of minutes now, and we're going to go ahead and perform the percutaneous microtenotomy, also known as the dry needling. What we essentially do is we take a small gauge needle, you guys will see it now, and we're gonna, again, I've marked everything here. This is the fibula, right? This is the fibula, and we have 1, 2, and 3 very important ligaments. The one that's affected, the high-grade tear here, is the ATF, anterior talofibular. So it connects the talus to the fibula, talofibular. So again, I like to use, let's get a good close-up here. So what I'm gonna go ahead and do is, you guys already see the grid that I've created, and basically, I know, are you okay up there? It's a celery, probably the patient already felt that kind of like a celery-like feeling. That's the ligament. All ligaments are kind of celery-ish like, and right. And what we're essentially doing, just so everyone really truly understands, is we're in a micro cellular level, right? We're creating trauma on purpose. Well, how does that help? We're essentially trying to trick the brain into believing, and that's the, believe it or not, that's the first part of the procedure. We're trying to trick the brain into believing that there's a new injury. And if we can trick the brain into believing there's a new injury, stay right there, then the brain will decide that it wants to do something to try to continue to heal this chronic condition. Brilliant, right? So in addition to creating, you know, the trauma, now this is 3 cc's, to be exact, 2.6 cc's of PRP that we have already isolated. So now what we're going to go ahead and do, okay, I always tell the patient that they may feel a little bit of pressure, okay, maybe a little bit of dull, achy pain, sometimes even when the anesthesia has been achieved, okay. So a little stick, okay, and here we go. How you feeling up there?
Yeah, it feels a little weird.
Any pain?
Nothing.
Okay. Very slow. Right? Slow because we want to make sure that all that PRP. How you doing?
Good.
A little painful. Okay, we'll stop there. Okay. Yep. So come up here a second. The patient right now is a little uncomfortable. Believe it or not, I have the needle here. And it takes about a minute or two for that discomfort to go away. So we're gonna wait about a minute before we just do a little bit more, okay? It's a very dull, achy pain. The patient, I usually let the patient tell us when they're ready. So I know that in this area here, right, in this area here, she does feel a little something, even with the anesthesia, right? So we'll just wait a second or two. It will go away. She's breathing. So I just want to move I'm not going to do anything. So again, we have infiltrated the PRP here, and now we're going to go ahead and just finish up here. Okay, we'll just wait for her, for the green light here. This is no joke. I'm telling everyone, and I tell in every video that I post concerning PRP, yes, it works fantastic, but in respect to pros and cons, you know, this is all volume expansion. It hurts. It's a dull, achy pain. I've had it done on myself. It hurts. Some people have, obviously, they tolerate pain better than others. And I tolerate pain well. It's starting to go away. It's starting to go away. What we're gonna go ahead and do is I'm gonna go ahead okay, and that's another reason why we infiltrate. Just relax a little bit.
Yeah.
Okay. I'm just gonna go ahead. She should not feel this either here. Okay. Are you okay? Okay. Are you okay? You okay? And you okay?
Yeah.
You okay?
Yeah.
Okay, good. And I'm asking the patient why, you know, are you okay? Are you okay? Just because I don't, okay, so then we'll stop there. And that's it. As everyone can see, right, as everyone can see, we've infiltrated the PRP to the ligament, and now we're gonna go ahead and inject the sinus tarsi with a little bit of PRP. Here we go.
Can we wait another minute? Can we?
We can wait 100%. So in the meantime, while we wait, let's talk. So we have decided to use, again, we've spoken about the low level, mid level, high level, different PRPs, kits that we use, 30 cc's, even 60 cc's, depending on the clinical presentation. We've even gone to 120 cc's for different clinical presentations. So after thousands and thousands of injections that I've done, PRP injections, I have my own protocol that I've sort of developed in my mind. You know, what's gonna work the best for the patient. And in a case like this, you know, we were able to draw maybe 20 cc's plus. And I think that, you know, the more, obviously in certain situations, more blood, more PRP, more concentration, the better the outcome. And you know, the sinus, in respect to the sinus tarsi, it'll work well. I think it'll work better because it's a joint. The good thing about the joint is that it'll stay within, the PRP will stay in the joint. But in my experience, she will do really, really well with the microtenotomy and the needling and the PRP. They just simply love each other. They love each other, right? So, and it doesn't mean that I have to, again, it doesn't mean that I have to inject all of this into that little joint, the subtalar joint, the sinus tarsi. It's better. Can we proceed? Okay, here we go. Just in case I'll have a little bit of the cold spray. So this is the sinus tarsi. She's definitely numb here. I know she is. Okay, so here we go. She may feel discomfort, not, just because we didn't numb the area all the way in there. Okay, so there we are, right? We're in the joint. And now what I'm gonna tell the patient is that she may feel the dull achy pain. Some people do, some people don't. So without further ado, I'm gonna, infiltrate very slow. And if it's too much discomfort for the patient, then we will stop. There's a moment of silence here, which is not a bad thing. How are you doing up there?
Starting to feel discomfort.
A little bit, or should we stop here? I think it. Huh? What do you think?
Almost done.
It's okay? It's hurting?
Yeah.
Okay, so then we're gonna stop right here. Okay, I'm happy with 0.6 cc's. Okay, so the procedure is done. I'm happy with 0.6 cc's. That's very good. The patient will feel discomfort. PRP causes an inflammatory response, and that also tricks the brain into believing, again, we're trying to trick the brain, not only that there's trauma, but now we have delivered, right? Whoosh, this cascade of PRP, and that's gonna really, really, really help this patient. This is a patient who has been battling this for more than 5 years. So we're like a salmon swimming against this huge current. If I can get this patient to feel 50, 60, 70, 80% better, then that to me is success, right? Better. I'm not in the business of promising 100%. I'm in the business of helping patients. And I think that's, we'll leave it at that. There's a possibility once we, stop the video that the patient may say, you know what, go ahead and just, put in maybe the rest. If she decides that she wants to do that, I got no problems there. So like always, I hope you guys have enjoyed this wonderful video. Like always, www.jawspodiatry.com, Facebook Jaws Podiatry, Instagram Dr. Toe Jam, and last but not least, our YouTube channel, Jaws Healthcare. We're going to definitely post this video up today. This is a wonderful, just like we did here, we're able to do, these techniques into other parts of the foot and the lower extremity, as well as, believe it or not, the knee. So, like always, thank you for watching.